Welcome to This Explainer. It's wild to think the way we bill for maternity care hasn't really changed in decades. Well, buckle up, because that is all coming to a crashing halt. Today, we're systematically breaking down the massive, highly technical changes hitting obstetric medical billing. If you're anywhere near maternity care coding or practice management, you already know the landscape is about to experience a complete seismic shift. We're officially moving away from the old school methods we've used for a generation, and this transition, it's going to require absolute precision. So let's jump right in and get you fully prepared.
January 1st, 2027. Circle that date, highlight it, put it on your calendar right now. That's the exact moment the old one-size-fits-all global billing approach for maternity care disappears forever. Think of the old global model kind of like buying a single ticket for a 9-month train ride, where everyone is forced to take the exact same route, no matter what happens along the way. Sure, it was meant to simplify things, but let's be real. It completely fails to capture the actual clinical complexity of a modern pregnancy. So, the industry is stepping in and forcing a massive change. Okay, here's our agenda for today to get you up to speed. 1. The 2027 Maternity Billing Shift. 2. Global versus granular care. 3. The new EM code breakdown. 4. Diagnostics and fetal monitoring. And 5. Modifiers and special cases. Let's do this.
Starting off with Section 1, the 2027 Maternity Billing Shift, a massive code overhaul.
As you can see, we are officially waving goodbye to 17 outdated codes, bringing in 12 entirely new ones and revising 6 more. This isn't just, shuffling paperwork around. It's a fundamental separation of antepartum care, labor management, delivery, and postpartum care. Every single phase now demands its own unique code. Why? Because you can no longer bundle these distinct phases into one neat little package. The new reality demands a highly granular approach to capture the exact scope of care for every single encounter. The AMA is completely overhauling subsection guidelines and reordering existing codes. This means when a provider manages a complex labor, that specific effort is documented and billed independently from the routine prenatal visits that happened months ago.
Moving right along to Section 2, Global versus Granular Care, the philosophy shift.
To really understand these new rules, we need to establish our baseline definition for antepartum care, or as we usually call it, prenatal care. By definition, this encompasses every single clinical encounter from the initial diagnosis of pregnancy right up until the onset of labor. Now, why does getting this definition right matter so much? Because in the 2027 system, the clock starts ticking the exact moment a pregnancy is confirmed. Every single clinical touchpoint from that second until labor is under a microscope, and how you document that period is changing from the ground up. Historically, we've operated on a super rigid, calendar-based model, right? 12 to 14 scheduled face-to-face visits no matter what. It was literally like an all-inclusive resort package, where everyone gets the exact same itinerary, one appointment every 4 weeks until month 7, then every 2 weeks, then weekly. But fast forward to 2027, and welcome to the era of granular care. Your coding must now directly match the tailored evaluation and management, the EM service, provided on that exact day. Every encounter is now treated as a totally unique event, coded based on the specific care delivered.
Now, this tailored, granular approach didn't just fall out of the sky. It follows directly on the heels of ACOG's new clinical consensus on how prenatal care should actually be delivered. And honestly, it makes total sense. A patient with pre-existing hypertension or complex social determinants of health obviously needs a vastly different care schedule than a low-risk patient. ACOG's new guidelines finally recognize this reality. They dictate that care schedules must be driven by clinical factors, things like patient need, medical comorbidities, pregnancy complications, and even patient preferences. We are totally abandoning the one-size-fits-all calendar on the wall.
That brings us to Section 3, the new E&M code breakdown, mapping the encounters.
Okay, so instead of that old blanket approach, you now have to map every single encounter to its specific location and intensity. This table right here, this detailed coding update summary, is going to be your new daily playbook, so pay close attention to all the important points in text on the screen for the best understanding of how this breaks down. If you see a patient for a standard office or outpatient visit, you're pulling from the 99202 to 99215 series. But what if it's a virtual check-in? Then you're shifting to code 98016 or the 9800 to 98015 series for telemedicine. If care is provided in the home or a residence, you're looking at the 99341 to 99350 series. And this scales all the way up through initial hospital, inpatient, and observation codes, the 99221 to 99236 buckets, and even covers critical care with codes 99291 and 99292. You've got to pinpoint the exact setting and map the exact code every single time. No exceptions.
Let's jump to Section 4, Diagnostics and Fetal Monitoring, Separate Reporting Rules.
If you take away just one crucial thing from this section, let it be this. Diagnostic and therapeutic procedures performed during the antepartum period are now reported entirely separately from and in addition to your E&M codes. So whether it's an obstetrical ultrasound evaluation, which falls under code 76801 to 76828, or a fetal MRI under 74712 to 74713, these are entirely distinct events. Also, if an outside consultation is requested for a pregnant patient, assuming it's outside of fetal heart monitoring, you just report that with the appropriate E&M codes. If you mistakenly bundle these specialized procedures, you are literally leaving crucial practice revenue on the table and opening yourself up to compliance audits.
Speaking of things you can't do anymore, say goodbye to CPT code 59050 for fetal monitoring during labor by a consulting physician. It is deleted. Completely gone. Moving forward, you must use code 59051 specifically for the interpretation and written report of a fetal heart tracing. Like I said earlier, the microscope on your documentation has never been more intense. You absolutely cannot rely on a generic monitoring code anymore. Your billing now requires hard proof of the specific interpretive work and the formal report generated from that exact tracing.
And finally, Section 5, Modifiers and Special Cases, the rules for Modifier -25.
Picture this. Your pregnant patient comes in for a routine obstetric check, but while she's there, she presents with a severe upper respiratory infection, or maybe she sprained her ankle. Because you're evaluating a completely unrelated issue on the exact same date of service by the same provider, you have to know how to properly append Modifier-25. This modifier signals a significant, separately identifiable EM service. But, and this is absolutely critical to avoid an instant insurance denial, the secondary issue must be entirely outside of obstetric or labor management. You must supply a diagnosis code completely unrelated to the pregnancy to support that separate service.
Along those same lines, you can no longer just vaguely jot down high-risk pregnancy to justify extra visits. In 2027, payers demand to know exactly why. If you're seeing a patient more frequently for high-risk surveillance, your documentation has to include the specific, appropriate diagnoses that clinically justifies that high frequency of care. Is it gestational diabetes, preeclampsia, advanced maternal age complications? Every single extra encounter must tie directly back to a precise, documented clinical diagnosis. Literally everything must be justified.
So that leaves us with the million-dollar question. Are your current documentation habits granular enough to survive the end of global maternity billing in 2027? This shift from a rigid, calendar-based global package to a highly specific encounter-by-encounter coding system is going to require a total transformation in how providers document their care. The days of the all-inclusive global package are officially over. The practices that survive and thrive through this shift will be the ones that master these granular details right now, today. So take a hard look at your workflows. Will your billing team be ready when the clock strikes midnight on January 1st?